It's difficult. The thing that's challenging is for atopic dermatitis, there is no diagnostic test. But for allergic contact dermatitis, there is. So if you have a patient with a moderate severe eczema and it's not improving with topicals, those patients are candidates for patch testing. And if you find an allergy and they get better, you know that there either was an exclusive allergic or part of the dermatitis was due to allergies. However, if you do patch testing and there are no allergens, then you know that their allergen is either irritant dermatitis or exclusively atopic dermatitis in nature. And the reason why that's important is that many of the drugs we use to treat atopic dermatitis, like lebrikizumab or dupilumab, will not be effective for most forms of allergic contact dermatitis. So identifying a precise cause is very important because not all treatments will work for all forms of eczema. The first thing is we always need more people to do patch testing. And I'm someone who specializes in advanced patch testing. I have 500 allergens in my clinic. I routinely test patients to more than 100 allergens. And technically, yes, that is the ideal way it should be done, but that's not the only way that it needs to be done. And if you're someone who can only do the American Contact Dermatitis 90 allergens, or even just the true test, it can still be helpful. We need more dermatologists who are willing and capable of doing patch testing because it can be transformative for many of our patients with chronic eczematous dermatitis. The second thing that I would emphasize is you need to read labels. One thing that I encourage all of you to do is the next time you're at the grocery store, you're at a pharmacy, and you're looking at shampoos or lotions, look at a bunch of them. Look at the ingredients. Are there new chemicals you haven't seen before? Are there certain chemicals that you used to see all the time, like methyl isothiazolinone, that just aren't there anymore, or methyl dibromoglutarol nitrile? Some chemicals become popular and then they go away. And I think it's very important for us to know what are the chemicals that our patients are coming in contact with so that we can better identify potential causes and really tailor our patch testing to their needs. Yeah, it's two things. One, I do think actually this CHE. As a patch tester, CHE has been my bread and butter for as long as I've been doing this. So it's nothing new. But for many derms, they're not familiar with the concept. And so I think having a greater awareness of CHE is incredibly important because it has so much morbidity for our patients. The second thing is CSU is continuing to take the spotlight in dermatology, which is great. Historically, dermatologists managed chronic spontaneous urticaria. For many years after omalizumab came out, dermatologists kind of was referring these patients to allergy, but now with the approval of remibrutinib and dupilumab, I think we're starting to see dermatologists continuing to take back and treat more CSU, and I think in 2026 we're going to see an explosion of that.